lecture is about excretion of drugs. The major routes of drug excretion are renal, biliary, fecal, alveolar, excretion through skin, hair, nail, and excretion through breast milk. There are three processes that determine the renal excretion of drugs. These are glomerular filtration, tubular secretion, and passive tubular reabsorption of drugs. The factors that influence glomerular filtration are molecular size, plasma protein binding of the drug, and renal blood flow. The first factor is the molecular size. Drugs with a small molecular size are easily filtered through the glomerulus, but drugs that have a molecular size of greater than 20,000 are unable to be filtered through the glomerulus. So this acts as a hindrance to glomerular filtration. Examples of drugs which have large molecular size and are not easily filtered through the glomerulus are heparin, dextran, and insulin. The second factor is the plasma protein binding of the drug. Drugs which have high plasma protein binding capacity are not easily filtered through the glomerulus. So plasma protein acts as a hindrance to glomerular filtration. So only the free drug is easily excreted by glomerular filtration. Example, warfarin has 98% plasma protein binding capacity. So only 2% of the drug is excreted by the glomerulus. So greater the plasma protein binding capacity, lesser is the glomerular filtration, and lesser is the plasma protein binding or greater is the free drug in the plasma, easily the drug is filtered through the glomerulus. So for the drug to be easily excreted through the glomerulus, it has to be in free form and the plasma protein binding capacity has to be very less. The third factor is the renal blood flow. Greater is the glomerular perfusion, faster is the elimination of the drug through the glomerulus. If the renal blood flow increases, the glomerular filtration increases, but if the renal blood flow decreases, for example in congestive heart failure, renal failure, the renal blood flow decreases and this decreases the glomerular filtration rate. So to sum up, the glomerular filtration depends on molecular size, plasma protein binding capacity and renal blood flow. The second process through which the drug is excreted through the kidney is tubular secretion. The drug that reaches the kidney, about 20% of the drug is excreted by glomerular filtration and rest 80% is eliminated by tubular secretion. There are two independent carrier systems that operate in the distal part of the tubule and they facilitate the removal of the drug from the tubular lumen. So the carrier systems, which are protein molecules, facilitate the removal of drug from the plasma into the tubular lumen. As mentioned earlier, plasma protein binding that acts as a hindrance to glomerular filtration is easily removed by the process of tubular secretion. This occurs with the help of carrier systems. So these are transporters or protein molecules that facilitate the removal of drug from the plasma into the tubular lumen and the drug is excreted out. So, as the free drug in the plasma decreases, the drug that is bound to the plasma protein is dissociated from the plasma protein and is removed by tubular secretion. Some of the clinical applications of tubular secretion are, for example, drugs with same physiochemical properties compete with the same transporter for secretion into the tubular lumen. Example, penicillin and probenecid have same physiochemical properties and compete with each other for the same transporter. So probenecid is a weakly acidic drug and it has high binding affinity for the carrier transporter. So it binds with the transporter and prevents the binding of penicillin to the carrier system, and this prolongs the action of penicillin in the plasma, increasing the concentration of penicillin, and this increases the efficacy and the antibacterial action of penicillin. Thus, penicillin and probenecid, when co-administered together, decreases the excretion of penicillin, increasing the concentration of penicillin and increasing the antibacterial action. Similarly, weakly acidic drugs such as thiazide diuretics and salicylic acid decrease the excretion of endogenous substances such as uric acid, increasing the concentration of uric acid in the plasma, and this causes precipitation of gout in susceptible individuals. The next factor that influences renal excretion of drugs is passive tubular reabsorption. So the drug that is filtered through the glomerulus and enters into the tubular lumen is reabsorbed through the tubular epithelium by passive diffusion. So tubular reabsorption depends on three factors. First, lipid solubility. Second, pKa or pH of the drug. And third, pH of urine. The first factor, that is lipid solubility of drug. Greater the lipid solubility of the drug, greater is the reabsorption of drug from the tubule into the plasma and lesser is the excretion of the drug. So higher the lipid solubility, lesser is the excretion of the drug and greater is the reabsorption. The other factors that influence tubular reabsorption of drug are the pH of the drug and pH of urine. So an acidic drug in presence of alkaline urine ionizes, and since the drug is in ionized form, it is less lipid soluble and is easily excreted. So this principle is made use in the management of salicylate and barbiturate poisoning, where the drug needs to be removed from the body, and since these drugs are acidic in nature, the urine is made more alkaline so that it undergoes ionization, and ionization decreases the lipid solubility and increases the excretion rate, and therefore the drug is easily removed from the body. Similarly, for basic drugs such as morphine and amphetamine, the urine is made more acidic in presence of ammonium chloride and ascorbic acid, and this increases the ionization and enhances the excretion of drug through the tubular lumen. In case of acidic drugs, the urine is made more alkaline in presence of sodium bicarbonate and sodium citrate, and this enhances the excretion of acidic drugs. But in case of basic drugs, the urine is made more acidic in presence of ascorbic acid and ammonium chloride, and this enhances the excretion of basic drugs. However, strongly acidic and basic drugs remain ionized at all pH ranges, and since they are in ionized form, they are not lipid soluble and are easily excreted without getting reabsorbed. So these drugs include quaternary ammonium compounds and aminoglycoside antibiotics that are excreted as such in urine. As we know that the rate of elimination of drug influences the duration of action of the drug. So if the rate of excretion decreases, the drug accumulates in the body and this can lead to toxicity. Therefore, these drugs should be administered with caution in elderly patients with renal disease and other acute diseases where the excretion or the elimination rate of the drug decreases and the drug accumulates in the body, and this can give rise to side effects. As we have learned that the kidney is the major organ that is responsible for excretion of drugs. The other routes of drug excretion are biliary excretion and enterohepatic circulation, fecal elimination of drugs, alveolar excretion, excretion of drugs through breast milk, and excretion of drugs through skin, hair, nails, and sweat and saliva. Coming to biliary excretion, liver cells excrete drugs and endogenous substances from the plasma into the bile by means of transport systems. The drugs that are eliminated through bile include quinine, colchicine, D-tuberculadine, corticosteroids, and erythromycin. Some of the drugs that are excreted into the bile undergo enterohepatic circulation, which means that the drug is delivered into the intestine after getting excreted by the liver, and it reaches the intestine where it gets reabsorbed and then reaches the liver and is again excreted into the bile. So, in this way, recycling of the drug occurs, and this leads to prolongation of effect of the drug. Some of the drugs that undergo enterohepatic circulation are morphine, diazepam, metronidazole, tetracycline, chloramphenicol, and so on. Some of the drugs and endogenous substances such as bilirubin, steroidal hormones, and thyroxine are delivered into the GI tract where they undergo deconjugation and are hydrolyzed by the gut enzymes into active drug. This active drug is reabsorbed by the portal circulation and reaches the liver and is then excreted into the bile. So in this way, recycling of the drug occurs and this leads to prolongation of action of the drug. So the net effect of enterohepatic circulation is prolongation of drug action. So at lower doses, the drug can be therapeutically effective. Secondly, this principle can be applied in case of poisoning. For example, in case of basic drugs such as morphine, which enters into the stomach and comes in contact with acidic pH. So a basic drug coming in contact with acidic pH ionizes. So the predominant ionized form of the drug is non-lipid soluble and is not reabsorbed or is poorly reabsorbed by the stomach epithelium. So it is at this stage that the drug, that is morphine, should be removed by gastric lavage. Otherwise, it would reach the intestine and the basic drug coming in contact with alkaline pH would lead to poor ionization, and the poorly ionized drug is lipid soluble and is rapidly reabsorbed into the circulation. So in case of poisoning with drugs such as morphine, the drug has to be removed by gastric lavage before it reaches the intestine and is absorbed into the circulation. The next route of elimination is fecal elimination. So drugs that are orally ingested reaches the intestine and are not reabsorbed. So these are the drugs that are poorly absorbed in the GI tract and are excreted or eliminated through feces. For example, magnesium sulfate, streptomycin, neomycin and bacitracin are examples of drugs that are poorly absorbed in the GI tract and are eliminated. The next route of excretion is alveolar excretion. Gases and volatile liquids such as N2O, ether are eliminated through breath, and partial pressure of these gases in blood determines their excretion. The drugs can also be excreted through breast milk. Generally, the basic drugs are excreted in higher concentration in breast milk compared to acidic drugs. As we can see here, the plasma pH is 7.4. So basic drugs in presence of alkaline pH remains non-ionized, and non-ionized form of drug is more lipid soluble. So since it is more lipid soluble, it can easily diffuse through the mammary epithelium and enters or accumulates in the breast milk. When it reaches the breast milk, the pH is 6.4, it is relatively acidic. So it ionizes, and the ionized form of the drug is non-lipid soluble. It gets trapped in the breast milk and is not reabsorbed back into the plasma. Therefore, basic drugs such as morphine, diazepam, metronidazole, tetracycline, chloramphenicol ionizes and is trapped in breast milk and is secreted in breast milk. However, acidic drugs, although they are excreted in lesser concentration in breast milk, can cause side effects. For example, sulfonamides can cause kernicterus and allergy. Penicillin can cause allergic reactions, ampicillin can cause diarrhea as a side effect, and phenobarbital can cause drowsiness as a side effect. The drugs can also be excreted through skin, hair, nails, saliva and sweat. Examples of drugs that are excreted through skin are griseofulvin that gets secreted through the keratin precursor cells, and metals such as mercury salts, arsenic and iodides get secreted through hair follicles.
These are my references. Thanks for watching. Please like, subscribe and share.